You show there at the top episode window, and I certainly understand what you mean by PCI being a trigger. You show the angiogram as a pre-trigger. What does pre-trigger mean in the tracking system that will be in place for this?
Pre-trigger just indicates what costs before the trigger, before the procedure are included when the window starts. So to take an example, if the payers look in the claims data and saw a PCI on Monday triggered an episode, and there was a diagnostic angiogram actually on a Sunday, the episode would start on Sunday. It would continue for 30 days after discharge from the actual PCI procedure, and then the related costs that I mentioned during that window would be included as part of the episode. Does that answer the question?
Yes, thank you.
If there is a PCI event, that will be the trigger. If you have billed a claim and you've been paid, so assuming that it's been put in, so the paid claims are there, if that is a PCI, it would trigger the episode. We update the codes, and we will then...
But you need to see those, because each code, one of them is if it's a total occlusion. One of them if it's happening during an MI. I can't remember the rest of them, but every code for your PCI changed for 2013.
So what you're saying is that you'd have to do a different kind of risk adjustment.
Yes.
And that's fine. We will be, and as Matt said, we will be doing our risk adjustments with the claims that we have. So that's a constant process of this episode of care.
But you don't have that here for us to see.
It's hard to risk adjust with claims that we don't have in the claim set. If 2011 is the data you have before you, and those codes didn't exist in 2011, it's hard to use those codes. We are showing you the framework at this point in time of how the 2011 would look in terms of if the episode of care existed in 2011. We will make adjustments with the new codes for 2013, but the conceptual framework of how we develop the episodes and the comparative data will be reflective of what we've done here. Granted, we'll have different codes, but we're giving you the idea of how we're setting this up to do comparative performance.
And just to kind of, as an assurance, if the definitions of the codes change to where a risk adjustment model developed on older data is no longer applicable to new claims, we're obviously going to have to accept that and account for it. Like, we can't hold you to a standard that's no longer applicable. And that's, we're aware of that, and we'll make sure that that's handled properly.
And I appreciate the comment very much. And as the payers move into kind of releasing reports and so on, all the actual codes moving forward will actually be published. There's a little table that gets posted on the website Bill mentioned that has all the specific codes. So again, thank you for the comment. I think it's an excellent one. This is only looking at historical data based on the claims that have been submitted historically for discussion in this group, and the codes for the actual episode looking forward, and any new codes would be posted online too. Thank you very much, though.
But my question is, in the case of STEMIs or even non-STEMIs, and you elect to do an intervention of one or two vessels, and then for not necessarily end-stage renal disease, but just chronic renal insufficiency or other comorbidities, you would like to do a stage intervention at a later time, how is that going to turn out? Is it still going to have to wait 30 days? What if the lesion is critical and it should be addressed earlier?
Yeah, and actually, right now, let me take a few, because I'm hearing a few questions out. Let me take actually a few questions that are going to come in to see if there are any common themes as well that we can address kind of in one, and I may pass the microphone off to some of our clinical advisors or others. So I heard that question there. Let me just repeat it to make sure I'm understanding it. It's a question of for multiple vessels, how is that going to be accounted for? Is that right?
No,
especially
it's more
with respect
about a stage type of intervention. If you, for comorbidities, you cannot treat all the lesions at the same setting, but there are several lesions that are critical, being anemia or being chronic kidney disease or others that I can't think of right now, but the lesions are critical, and you may elect to wait 1 or 2 weeks before you address the second target. how is that going to be accounted, or are we going to have to wait 30 days and sit on a critical lesion for 30 days?
Okay, great. That's a great question. Thank you for that. Are there any other? If we can pass the microphone to the gentleman here.
I had a second question. It's related to what was just asked about, because the exclusion on page 33, it mentions severe chronic disease. It says end-stage renal disease, so I would expect that implies patients on dialysis or pre-dialysis. Now, those will change how patients will do in long term and will change the risk. If they are different stages of renal failure, by doing interventions, you're pushing them forward. And that would make you wait for more procedures until the kidney function resolves. So that potentially should include not only end stage, but renal insufficiency graded according to the degree of renal insufficiency. Secondly, on the code status, a question on my part is, I don't see any part, or at least it's not obvious to me from the intervention standpoint, is does it take into account the nature of the lesion? We grade the lesions according to their nature based on various factors, either type A, B, or C. A single lesion that requires one stent may be type A, which can be easy to fix and slightly cheaper, versus a type C lesion that will take a couple of hours and a lot more intervention, a lot more time, a lot more dye, and would predispose patient not only to longer procedure duration, but also increased dye and all that stuff. I just wanted to check if that's taken into account, because every lesion is different at the time of intervention. And does the cost reimbursement take into account those?
Thank you.
For treating chronic total occlusions in coronary arteries, the expense of the case and the complexity of the case will be different from routine angioplasty. How can that be treated in this situation?
Great, thank you. Okay, so I heard a few questions here. One was on staged interventions. How is that handled in the episode model, and how will the episode model account for that? I heard a question on ESRD is listed as an exclusion right now, but there are other degrees of renal insufficiency that would affect the treatment pathway as well, so how is that accounted for? A question also about the code status, the nature of the lesion, and how that would be accounted for, and on the occlusions here, how that's accounted for. So a lot of questions on for different natures of the different risk factors and different patients levels of patient severity. How will the episode model handle that? I have one question on the first one, and then I'm going to ask just some other clinicians in the room just to comment on any thoughts on the degree of kind of severity across each of these. On the point about staged interventions, I'm sorry I don't remember who asked the question. I think it was from one of the video conference sites. Can you describe to us a little bit about your sense of when staged interventions and under what kind of clinical situations are most appropriate, and are there specific conditions that we could use to risk adjust or account for the difference of those costs?
Yes. Well, there's many different settings. If you have, like they mentioned before, illness such as chronic kidney disease, and it doesn't have to be end-stage renal, but perhaps you have an elevated creatinine approaching 2 or above 2, and you have 2 perhaps complex lesions to treat, and you don't want to put the kidney function at risk, and you want to, again, stage the procedure. That would be one circumstance. A second circumstance would be in the setting of a STEMI. The clinical guidelines say that you only have to treat the culprit vessel. So what if the culprit vessel's, say, a right coronary artery, but you have a critical lesion in a proximal LAD that is prognostically very important, and you don't want to necessarily sit on something like that for 30 days?
Part of my question is just to understand, are there things we can look at that are coded in the claims that you could therefore use to adjust the cost of an episode when you look at historical data? So I heard chronic kidney disease. In the case of STEMIs, we've heard it from other clinicians at points. Diabetes, is that one that clinicians feel would have in the room or at the video conference sites feel would have an impact on whether or not a stage intervention is I heard patient preference as another example.
A lot of time when you're trying to fix one lesion, it takes a long duration of time, up to 3 hours. For a younger patient, it's possible for him to go through the procedure lying still on the back, while you know you're going to be done in 4 hours. A lot of time, people with back problems or other issues, restless leg syndrome, or even psychological issues, cannot lie still for 2 hours. And after that, either they're not going to cooperate for the patients. In those situations, for patient safety, is there a consideration that patient is more restless, not tolerating sedation any longer, consider staging the procedure. So that's what sometimes based on a patient, how's he doing during the procedure to stage a case.
Okay, great. I see, and there's another comment on this in the back.
Just the same thing, adding to the same thing. Sometimes the severity of the lesion could determine if the second one should be staged. I mean, if you have a culprit lesion that's very complex, you don't want to be intervening on the second lesion. So again, severity of the lesion.
And a question for severity of the lesion, is there anything that currently would be coded into administrative claims data that would indicate the severity of lesion, or is that something that we would not find at all in the claims data, that would only be kind of clinical judgment and in medical charts and so on?
So this is Phil Riley in Fayetteville. Can you hear me?
Yes. Let me just let one more response to this particular question in the room, and then.
Well, I was going to answer it for you.
Oh, please. Okay.
So
please continue.
So right now we're using the NCDR database with the American College of Cardiology, and sites that use the NCDR database are required to submit the lesion severity, and that should help in coding if you guys can get that data.
So I just heard for the staged interventions, chronic kidney disease, STEMIs, quite a number of factors going into patient preference, from age to other conditions, whether it's RLS or other things of that sort, severity of the lesion. Are there any other factors that need to be taken into account? Yes. For folks on the video conference site, apologies if you couldn't hear that last one. It was a further comment on the NCDR database that it's voluntary. There are additional kind of investments from the providers that are required to be able to report that. Was there, actually, I heard a comment that was about to come in from the video conference site. Was someone about to make a comment or a question?
Question, if a patient has, for instance, two vessel disease, if a stent is placed in the first vessel and then we wait 31 days to do the second vessel, and that would that be a second episode if we wait 31 days? And if so, how do you determine whether we should go ahead and do both vessels at one setting or wait 31 days and make a second episode?
We went through, it's very helpful input from the group on some of the different reasons for when a staged intervention would be appropriate. There was one question about if kind of the timing of the staged interventions. At the moment, the episode design as is, if a second PCI happens, if the second intervention happens 10 days after the first trigger, that would be included as part of that episode if it's within that 30-day window. If it happens, 65 days later or something like that, that would be a separate PCI episode for the patient. Do folks have any sense, are staged interventions, are those always appropriate for the nature of the patient, or do folks have any sense of, are there any times when there's actual practice variation or judgment in whether to use a staged intervention or not?
Before you get there, just as a comment, I think we've run some data. We've talked about staged procedures with our work group, and we understand there is a certain percentage, I think it was like 15 or 20% statewide. 7%? Okay, 7% that are staged. So, the bottom line is going to be, if on an episode based on a normative basis, if you're in the 5 to 15% range, you're like everybody else. On the other hand, if you're at a 50% range, you're not. So the question then is, what is the practice variation and the risk factors? Because in a sense, if everybody is taking care of a similarly risk-adjusted population, their staged procedure rate should be somewhat comparable. Yeah. Happy to hear comments about that if there's a disagreement on that framework.
No comments on that? Okay, let's move on. I think this is extremely helpful feedback for the payers. I think one of the next steps here, there are some analyses that are underway to really understand in addition to the fact that 7% of PCIs are staged, what's the variation in that, what's the reason for that, and then there will be different adjustments and things likely that would account for that. So thank you for that feedback.